and welcome. Thank you so much for being with us today for our webinar, Strengthening Healthcare in Zambia. Um, we're just going to allow a little bit more time for people to come in, so please excuse that. For those of you who don't know, my name is Candice, and I serve as the Communications Coordinator at EMI South Africa. We are a Christian development organization that partners with communities around the world using design, planning, and engineering to help create places where people can thrive. And today we're super excited to take you behind the scenes of EMI South Africa's healthcare work in Zambia and share how partnerships, thoughtful planning, and long-term visions are helping strengthen healthcare facilities and systems across the country. So you're going to be hearing a lot from Gerard van der Merwe, who is EMI South Africa's Office Director, and Mpanji Sankala, who's our public health specialist who's based in Zambia. Together, they'll share insights from the field, lessons learned through recent assessments and projects, and some opportunities that lie ahead. So yes, following the presentations, we will have some time for questions. So please feel free to submit those questions in the chat box throughout the webinar, and we'll have a little bit of time at the end to ask both Gerard and Mpanji those questions. And before we begin, I'd just like to open up some time in prayer. If we can close our eyes together. Dear Lord, thank you so much for the opportunity for us to gather here and to learn about the work that you're doing in Zambia. I just pray, Father, for wisdom, clarity, and confidence for Gerard and Mpanji as they share experience and insight. And I pray for guidance over the current and future healthcare projects in Zambia, and that there'd be lasting and meaningful impact. And I also pray, Lord, that you will just open doors, provide resources, and raise up the right people, Father, to lead and support the work that we're doing in Zambia. In your name, Lord Jesus, amen. Right, Gerard, if I can hand it over to you. Oh, you're on mute. Can we?
Great. Let me start by sharing my screen. There we go. Good morning, good afternoon. I am sitting in a beautiful and sunny Cape Town. We have a gorgeous winter's day. It's still cold, but beautiful out. My name is Gerard van der Merwe, or Gerard, or G, whatever you find easier. I am the director of the South African office. My background is in architecture and urban planning and design. And I find myself embedded in some of these healthcare projects that we're doing. I'm doing this presentation with my colleague Mpanji. Mpanji, do you mind introducing yourself?
Hi, G. Hello, everyone. My name is Mpanji Sankala. I'm a public health specialist working for EMI South Africa. I'm based in Zambia. And it's good to join this webinar.
So the flow of this presentation is Mpanji is going to lead us through just a very high-level overview of healthcare and specifically healthcare infrastructure in Zambia. Then we will be talking about one of our projects, Minga Mission Hospital, and what we're doing there. After that, I'll hand back to Mpanji to talk about the strategy that we're doing for one of our donors and the Provincial Ministry of Health in Zambia. We'll look a little bit of where that work is heading, and then just some conclusory remarks from myself and looking ahead. We'll also chat a little bit of how you can get involved if you are interested in doing so. So with that, just very briefly, where in the world are we? For those of you not familiar with Zambia, I hope you can see my little pointer. I'm sitting here in Cape Town at the tip of Africa, actually not the most southern point as many people think Cape Town is. We're slightly towards the northwest. But Zambia is a landlocked country, really in the center of Greater Southern, or if you prefer, Sub-Saharan Africa. EMI South Africa is responsible for Greater Southern Africa, including Zambia. And we've found ourselves very active in Zambia, primarily in healthcare, also in education and other sectors. And therefore, this presentation, we're involved in a whole number of projects, too many to mention in this short presentation. But if you're interested in the work, there are ways that you can connect. So I'm going to ask Mpanji, who is Zambian and much more familiar with healthcare systems in Zambia, to just do the introduction in terms of what is going on in healthcare in Zambia.
Thanks, G. So this is a map of Zambia. There we put a pin at Eastern Province, but that's where Zambia has 10 administrative provinces, more of like counties in other countries. So we are doing most interventions there in Eastern Province, but largely this is Zambia with its 10 provinces. And the Ministry of Health is responsible for administering health in Zambia. And therefore, there are a lot of layers in terms of administration. There's a district level, provincial level, and overall at the national level. So Zambia does face a significant disease burden in terms of communicable diseases such as malaria, HIV, and STIs, and also some non-communicable diseases that have also been on the increase. However, the national priorities for the Ministry of Health in Zambia is to strengthen prevention and primary health care. And this is being done through many ways, through the involvement of community health assistants, community-based volunteers who support the work of the health facilities in the community. And also, there is also a lot of focus on maternal, neonatal, and child health services, as well as communicable diseases, like I said, malaria, HIV, STI, and TB. A lot of progress has been made in terms of reducing the prevalence rates of malaria, of HIV, but still there's significant work to be done there. And also, much more recently, we've seen a surge in cases of cancer, diabetes, hypertension, and also the Ministry of Health has set up some clinics like the Cancer Disease Hospital that is meant to effectively deal with these rising cases of the NCDs. But also, there is also a priority to strengthen integrated health support systems. You can go to the next slide, G. Yes, so what could be the impact of design on healthcare delivery? So in that picture there, we have a picture of Mambwe District Hospital, which is trying to be turned into a general hospital. So it is a facility designed with British standards, a very good facility, and so with a very good design. So we've seen that design influences how people access care, you know. If a facility is not properly designed, I can give an example of you put an OPD and a lab very distant away from the OPD, then you would have a lot of patients carrying samples from the lab, from the OPD going to the lab, and that also delays the services that they can access at that health facility. So we've seen that a properly designed facility is going to properly guide the flow of patients. It would be good for triaging, but even in terms of investment, if you've done a good design, you would find that some of the facilities where we're intervening, you would find that there's a hill there. You put a tank at the hill. Instead of raising a stand for you to get good water pressure, just putting a tank at that hilly place of the facility environment, you'll find that you have very good water flow. So we can see that design really plays a very effective way in healthcare delivery. Next slide, G. Yes, so there's been progress, like I said, in terms of healthcare delivery, but there are still some challenges and some barriers that still exist. There you can see the maternal mortality ratio. Out of 1,000 live births, currently Zambia is standing at 187. So this has been a reduction around, in 2013, it was somewhere above 300. In 2018, it was at 278. Currently, it's at 187. The Ministry of Health would like to reduce this. They had a target in the National Health Strategic Plan to reduce it to 100. But there's also a sustainable development goal of having this reduced to below 70. Next slide, please. Yes, so in terms of understanding these challenges, the Ministry of Health, working in tandem with other partners, have identified this 3-delay model, which talks about how people are, how the challenge that people have in terms of generally accessing healthcare timely and adequately. So, and the first delay among these is a delay in seeking care. So there are many times when people delay to seek care, especially mothers, pregnant mothers accessing maternal health services. So not recognizing firstly that the situation that they have is an emergency, not interpreting the symptoms so well, knowing that in this stage I need to get to the hospital, and that could be impacted by the literacy levels, especially in the rural areas, but at times even in the urban areas. So where there isn't good literacy, people are not able to tell that they need to get to the health facility in time. But we also know Zambia being also, just like many other African countries, there's a lot of traditional medicine. At times people would want to use traditional medicine instead of going to a healthcare facility to access good medication. So the time that they might be going to the healthcare facility, you might find that they are going to the healthcare facility in a worse situation than they would have gone had they thought of seeking care early. The second delay. So the second delay is also the delay in reaching care. So this is also impacted by long distances to the facilities. Zambia is over 700,000 kilometers squared. So the land area is quite big, but even in the province where we're intervening in Chama, we've seen that some patients have got very long distances to cover to go to the next facility, but also even the poor road network. At times, we've seen that on a road that should take you maybe 1 hour, 30 minutes or 2 hours, you might end up taking 4 hours, and that also has an impact in people accessing care. In one of the districts that we wanted to visit early in April, in Chama district, we couldn't even get to that district because the roads were cut off going to the facilities that we wanted to go to. So, and you can imagine if people are being referred from that particular facility to a facility where there's high level care, it also gives a very big problem. The next delay. So the next delay is a delay in receiving care. So let's imagine a patient has sought care. They've actually, despite some of these constraints in reaching care, they've managed to reach care, but there's also a delay in receiving adequate care at the health facility. So this could be also impacted by the number of healthcare workers at that facility. We know that at times some of the healthcare facilities have inadequate healthcare workers, at times equipment to effectively deal with certain situations. We also talked of design. You might find that even how the design is done at this health facility, you might find that the maternity annex or the maternity ward is so distant away from the OPD or the main facility. So you might find that even with poor design, there is also that delay in receiving care, maybe inadequate good triaging, which can also affect how people are accessing services. Next slide. Yeah, so infrastructure development is a good intervention, and also the Ministry of Health, working in tandem with EMI, have come up with some interventions that we would like to work together with the Ministry of Health. Currently, EMI has an existing MOU with the Ministry of Health, but also with Eastern Province, and we would like to guide them. We know that the Ministry of Health, actually the Eastern Provincial Health Office, they do have an infrastructure strategy, but we are advising on this strategy, and through funding from our donors, We are constructing new health facilities in the province, and we are also rehabilitating some of the existing facilities that are there. And with these constructions and rehabilitations, we've also seen that there's also procurement that comes with the grants that we have. So, but despite these interventions, there's still an uphill battle. There's a lot of challenges that are there still in health interventions. We've seen that there's a lot of overcrowding at some of these health facility. There's also insufficient maternity annexes. We know that the Ministry of Health and the President would like every health facility in Zambia to be a delivering health facility. Eastern Province on its own has over 400 health facilities, but not all of these facilities have adequate infrastructure to conduct deliveries. Yeah, so also aging buildings, some of these health facilities that we've been to have been in existence for more than 50, 60, 70 years. And also that also has an impact in how they are going to effectively deliver health services. Next slide.
I think that's back to me. Okay. Thank you, Mpanji. So in some ways, Zambia is a typical example of healthcare in Greater Southern Africa. We have rapidly growing populations, still very significantly needing facilities for mother and child healthcare, and aging, sometimes ailing and failing infrastructure. Minga is I would say, a very typical example of this. It is a project, as with this whole discussion today, in the eastern province of Zambia, at a town called Minga. Minga is an old mission station of the Catholic Church. It's been in existence for about 100 years. The hospital, I believe, for about 70, 80 years. If I can just get my little pointer. The buildings in the foreground is actually the compound where the nuns stay. When we go and visit, we stay with them. And the buildings in the background are the main hospital buildings. We were approached about 3 years ago by one of our major donors, Helmsley. They had visited the hospital, felt that there was a good case for the upgrade of the facilities at the hospital, but asked EMI to do a full assessment of the existing operations and infrastructure at Minga. In some ways, Minga represents a shift that we have been slowly undertaking as EMI, from solely focusing on infrastructure to more and more looking at operations, looking at leadership, looking at the financial sustainability of facilities. And I'll speak a little bit more about that. But let me talk about the typical things that EMI does for those not that familiar with EMI. So we did the initial assessment, as I said, about 3 years ago for the hospital. That led to a grant application to the donor, which was approved. And the main focus of that grant is a major infrastructure upgrade at the hospital. So what are we doing? The main components is a new surgical suite. That's the building with a grey roof in the background. Significant upgrades to the children's wards, which is part of the main campus of the existing hospital. So that would be renovations, replacement of roofs, reorganization of the facilities, and then a whole lot of interventions addressing the engineering services. So the most obvious one is a very significant new solar generation capacity, getting the hospital completely off of the national electricity grid. We're still connected as a backup, but the hospital now generates sufficient electricity from solar with a full battery backup to fully run the hospital. We've also in the process of installing. This project is happening at the moment. Construction is ongoing. The photo that you see here is relatively recent, so it gives you a good idea of where we are. We're also doing a new medical oxygen plant. We're upgrading water. In fact, I should put a label on here. In the background, you can see the area cleared for new water tanks, and then new water distribution systems, new roads, new stormwater facilities, etc. So the upgrade and the initial assessment indicated that one of the key needs at the hospital is a new surgical facility. To give you a bit of that context, what happened was that during a surgery and a rainstorm, the ceiling in their existing surgical facility collapsed. Fortunately, not on the patient in an adjacent room, but in the actual surgical suite of the existing buildings, just to give you an understanding of the level of deterioration of some of the existing buildings. And surgery, specifically maternity-related surgery, is one of the biggest needs of the hospital. So the grades include a new surgical suite with 3 operating rooms, of which 1 would be dedicated to obstetrics. This is a photo from a similar perspective, but the significance of this photo is that was the first time the lights were switched on from the solar supply. So, as I mentioned, the hospital is now fully off-grid, a 470 kilowatt facility. I can't recall exactly the size of the battery storage, but certainly sufficient storage for a full day's usage. There is a generator backup as well, fully up-to-date system with inverters and battery storage. And importantly, the upgrade of the electrical systems throughout the hospital. With a lot of these older facilities, one of the biggest challenges is the incremental repair upgrades to electrical systems, not always meeting code and safety standards. So in intervention at a facility like this, we try and do a much broader intervention than just addressing the needs of the new facility. Similarly, with the water system, our water testing on site from the existing boreholes indicated significant contamination, both from pathogens and from just general water quality in terms of the soils and sedimentation in the boreholes. So installing a completely new water system with full water treatment, both for solids, suspended solids in the water, as well as I mentioned, for pathogens. And then the redoing basically of the water distribution system. Mentioned the oxygen plant as well. This is very important for the hospital from a long-term sustainability perspective, the ability to bottle their own oxygen. It then goes to a manifold system, but it also gives them a product that they can sell to other healthcare facilities, assisting with their long-term financial sustainability. So that brings me to what I mentioned at EMI is growing, very much growing in the understanding that when we intervene at hospitals and we do new infrastructure, that often actually isn't the biggest need or the primary need at the hospital, but that so many of these hospitals are operating in an environment of very, very significant resource constraints. To paint that picture for you, the budget for this individual hospital upgrade at Minga is a little bit more than the full annual budget of the Ministry of Health for the Eastern Province of Zambia. Let me just say that again, that you understand that. So the office of the ministry that administers 460 something healthcare facilities, their full annual budget, and they are responsible for maintenance and upgrade of many of these facilities. Their full annual budget is less than what it costs to upgrade one single facility. So the resource constraints are very significant, not only in terms of need for new infrastructure and infrastructure maintenance and upgrades, but also for operations. So we have found that in intervening at a hospital like this, we need to do more than just build new infrastructure. Of course, that's not EMI's speciality. We're planners, architects, engineers, construction managers, and more public health specialists in Panji as well. But we have been addressing some of these issues through some really critical partnerships. The gentleman on the left, obviously the medical professional, is Dr. Jason Fader. He is a general surgeon who has himself been part of a team redeveloping a hospital in Burundi that is now fully functional as a referral hospital. And he has been advising EMI in the healthcare work that we're doing, and is now also an advisor to Minga Hospital's leadership, looking at operations as well as clinical services. The gentleman on the right, obviously the business consultant, is a South African business consultant and lecturer at our local Stellenbosch School of Business, Daniel Steenkamp. Daniel has specialized over the years in advising faith-based nonprofits in long-term sustainability. So both Dr. Jason and Daniel has formed part of our team, and for approximately the 3-year period that we're implementing the infrastructure upgrades, they've been working closely with the team at Minga to also look at operations and financial sustainability, not only as presenting the hospital with a plan, but actually working with hospital leadership in the hospital leadership developing the plan and then implementing it, both in terms of general management of the facility, but also then clinical services. And then very importantly for us as EMI, as a faith-based organization, we always ask the bigger question. Are we only looking at the health of the people of Zambia? And that would be commendable and is very necessary. And I'm very grateful for all the partners that are not faith-based organizations that do so and do amazing work. But of course, for us as EMI, there is the bigger question, and that is, are we caring for people spiritually as well? And I think for me, that's one of the most exciting parts of the work that we've been doing at Minga. The lady in the foreground is Sister Esperanza. She's the hospital administrator. She's a missionary from Tanzania who has spent the last, Mpanji, how long has she been there? I believe about 20 years in Zambia as a missionary, running Minga Hospital with her team of sisters that you can see on the left-hand side. And I would say the thing that struck me most about Sister Esperanza is seeing her move through the hospital campus, knowing the names of each individual patient, specifically the young mothers who come and deliver there, and seeing the physical care combined with spiritual care that hospitals like these provide, and the amazing opportunity that it is, specifically in an environment where we're addressing a maternal and child health care, and where very often mothers would come and stay at the hospital for an extended period of time to receive that care. Just before I hand back to Mpanji, the obvious question that we started asking ourselves as we shifted from just doing infrastructure upgrades to really considering broader impact is what is the link between our various projects? Is there a broader strategy? Is there a broader understanding of intervention in healthcare systems, or are we really just intervening on an ad hoc basis as we receive funding? So in 2025, EMI approached the donor Helmsley and asked their support to do a strategy, because EMI and a number of other partners funded by Helmsley are already working in healthcare in the Eastern Province, for us to do a combined maternal and child healthcare strategy. And I'm going to ask Mpanji to speak about that.
Thanks, G. So, as G has highlighted, so the Eastern Province Mother and Child Healthcare Strategy was birthed out of the work at Minga, as he has explained. And so as part of this strategy, we are working with the Ministry of Health, trying to guide and collaborate with them in terms of the infrastructure strategy, and also suggest with them where it would be more prudent, to invest based on a variety of factors. And in this, we are also working with other mission organizations. We are collaborating with the Catholic Relief Service. We are collaborating with Living Water International. We are collaborating with Medicine for Humanity, so that together we can have a more coordinated impact, if we properly synergize our efforts, because all of these organizations are also doing some projects in Eastern Province. So in October last year, we took a survey of some health facilities. At that time, it was 18 health facilities, but we've increased on the number of facilities that we've assessed, bringing it to 21. And so Eastern Province has 16 districts, 16 administrative districts. So out of these districts, we did assessments in 15 districts. And we were assessing rural health centers, we were assessing level 1. You might be interested to know that the cascade of health services in Zambia and in Eastern Province is that firstly, we have health posts, we have rural health centers, we have level 1 facilities, level 2 facilities, level 3 facilities, and then tertiary hospitals. So we did an assessment of nearly all the type of healthcare facilities there. And out of the 21 health facilities, we had a short list of 4 facilities. So the top priority was Petauke District Hospital. The second is Nyanje Mission Hospital. The third is Chasefo Mini Hospital. And the fourth is Lundazi District Hospital. So out of these 3, Petauke, Nyanje, and Lundazi are all level 1 facilities. And Chasefo is like a mini hospital. It's like a hybrid of the rural health center, but with the services that it's providing, it's also providing level 1 services. That means that other facilities are also referring to it. And the selection criteria was based on the overcrowding situation at these facilities, the high patient numbers. We looked at their OPD numbers, the deliveries that they were having in a year, and also significant infrastructure needs. Like maybe Nyanje, we saw that there were a lot of infrastructure needs. Also the geographic location, like I'll talk about in the next slides, and also the potential to improve access to obstetric and maternal care, so that in these facilities, based on the setup, these facilities can be better equipped to do even C-sections, and also strong leadership capacity and the sustainability potential. Highly on this list is Petauke District Hospital. It did demonstrate a very good. Besides, I think in Eastern Province, out of those 400 healthcare facilities, it receives a third amount of traffic. Despite being a level 1, it receives a third amount of traffic, but it also demonstrated very good, strong leadership that can properly manage this investment if it's put there. Next. So out of this is a map of Eastern Province, and you can see it's shaped like an L, though facing the other side. And we have got a good concentration of facilities here around Petauke, around here in Chipata, in Lundazi as well, not so much, but we can see that around Lundazi, a lot of facilities are referring from Chama here in the north. They do refer patients here. So with this strategy, we saw that it was prudent that if at all we could make interventions at 3 of these hubs. Chipata is already well serviced. There's the Chipata Central Hospital and a lot of private health facilities, but even other government health facilities. So Chipata, Nob here, it's properly serviced, but would like to make interventions in Petauke and Nyanje so that we can have very good comprehensive services around this area, but also in Lundazi and Chasefo, so that even on this northern circuit, there is very good health services, so that people are not referred from this far north to Chipata, because just the road from Chama here at the tip, it takes about 6 hours for you to refer on a very bad road. And from Lundazi to Chipata, it's taking about 3 hours. So intervening there was also good. So as you can see there was Petauke and Nyanje on the eastern node, and then Londazi and Chasefu on the northern node. So that's a map of Petauke District Hospital, which has been selected highly, scoring highly out of these 4 shortlisted facilities. Would like to make an intervention there. Of course, currently we are still in the stages of proposal development. We've not yet accessed funding to make interventions there.
If I can maybe add, so the 2 projects that have been selected as Take and Nyanje as the next phases that we'll work at, and I want to refer us back to the 3 delays that we spoke of, and just briefly speak about that and where we're heading with these projects. So, in terms of specifically maternal and child healthcare, mortality rates, and the other negative health impacts. All 3 of those delays, the delay in seeking help, the delay in accessing help, and then the delays in the actual clinical care as well, all 3 are major role players in healthcare and therefore in a strategy to reduce healthcare. So the primary need at both of these facilities is a substantial, what the Zambian government would refer to as a maternity annex, or a fully functional maternity ward, consisting of delivery rooms, of pre and postnatal wards, consult rooms, and surgical capacity. So at Talke at the moment, they have a single single operating room, serving a general hospital that receives literally thousands of patients per month. So the proposal at both Petauke and at Nyanje is the addition of maternity annexes. Those are sized appropriately in accordance with the catchment area and patient numbers of those hospitals. We do consider the ability for future expansion as well. With that, similar to the work that we've been doing at Minga, the addition of a new operating suite meeting international standards. At Petauke, also to add a neonatal ward, specifically with a NICU, with a neonatal high care or intensive care capacity that would include kangaroo care, that would include the classic NICU services. A full suite of services related to maternal and child healthcare at both of these facilities, but also similar to what we're doing at Minga, to then assist them with some of their sustainability and operations planning. So continuing with the work that we've started at Minga for those facilities. So where are we heading? What is happening next? We, towards the end of last year, concluded the initial assessment phase. We're now in the detailed planning for proposals for Petauke and Nyanje, and in the future we'll look at further facilities. Those proposals will be going to the primary donor that has funded the Minga project as well as the study. But I think one of the things that we realized is there is too much to do in Zambia for us to do all of it from South Africa. The EMI way is local presence. We realized in the implementation of projects that we can't do so if we need to go and see a contractor, get onto an airplane and fly to Zambia every time. It's relatively easy from Cape Town. I can be in Zambia. And if I push it, I can be on site at Mingo on the same day, but more realistically, it's tomorrow. So we are in the process of launching a satellite office, initially under the administration of the South African office, but with the hope for it to in future be fully independent. Mpanji, that you've met today, together with Mutinta, are our first two staff members. Mutinta is based at Minga, and she is our uh, site agent for EMI, construction manager, if you prefer, at Minga. Panji is assisting with the healthcare planning work that we're doing, but also assisting with looking at what it requires to set up the office in Zambia. And then we have a new fellow. Nisa is a civil engineer, recently registered, recently qualified civil engineer. He has done a year-long internship in the South Africa office, and he will be joining the Zambia team. And then one of our young architects here in I'm aging myself by calling Henko young. One of our architects, let me not condescend. One of our architects, Henko, and his wife are considering joining our team in Zambia. So we're actively looking at launching that office in Zambia. We're currently looking at what does that look like in terms of legal entities, what is the relationship between South Africa, global, and the Zambia office, and then expanding the work that we're doing. As I mentioned, we're already have several projects in education. We have other hospital projects. In fact, we've got a team going to the north west of Zambia to Loloma in August to do a separate hospital assessment there as well. Um, and yeah, the obvious question that leads from that is, what about you? How can you be involved? How does this relate to you? I saw that there were a couple of people from Zambia interested in joining us. You may already be part of the EMI family. You may already be a regular volunteer. And I think the first thing that I want to say is stay connected. And the easiest way to do that, I'm sure you can check in the chat, and Candice would be posting already, is make sure that you're registered and connected on our website. If you go to the EMI website, there is the opportunity for you to register, and that gives you the opportunity to choose how you want to be connected. I'm sure Candice will say more about that. And then, very importantly, pray with us. If you do connect on the website, you have the opportunity to get our regular prayer calendar, but also just to stay updated. As I said in the discussion around the work that we're doing at Minga, the physical care is really important, very significant, but our final hope is that the work that we do will have a deep and lasting spiritual impact. We serve our clients, the doctors, the nurses, the hospital administrators, and with that, we see the impact that they have on people's lives, physically and spiritually. And we would love to invite you to keep praying for that. Pray for the work in Zambia, pray for the new office for Mpanji and Mutinta that are leading that with the South African team. As always with EMI, there are opportunities for you if you are a built environment professional, if you're an architect or engineer, construction manager, a healthcare specialist, for you to participate in the projects. So if you look at opportunities on our website, you'll see that very often when we do projects, there is the opportunity for people in the built environment to participate in those projects. Join us in Zambia. Come on a trip. Come and see the work for yourself and participate in some of the planning and design work that we do. And then, of course, EMI, as a faith-based nonprofit, rely on the financial support of people like you that either support individuals as they raise funds to be involved in the work that EMI does. All of our staff raise support, but also just general giving into the work that EMI does, and very specifically looking now at new work in Zambia. Also, if I can just do a shout out, we're similarly launching an office in Papua New Guinea, and the support that we receive from people is what makes those new endeavors possible. So I'm gonna stop there. I was given 45 minutes. I see on my stopwatch I'm on 44. That is very unusual for me to finish 1 minute early. Well done, Panji. We did it, 44 minutes. And I'm going to hand back to Candice and the team to manage questions and comments.
Well done, guys. Well done. 44 minutes is really impressive. We've already got one question lined up for you. So the first question I have here, for those of you who are here with us, please remember to send us your questions in the chat box and we'll try and get to those. So Gerard and Mpanji, the first question is there something different about Eastern Province? How did EMI's effort wind up focusing there?
Panji, I'll take this one if that's okay with you. Um, I think it's from an understanding. My background is in urban planning and design. And one of the key principles in urban planning is cumulative impact. So if you look at healthcare, if you look at even something as practical as crime prevention, the adding a second intervention and a third intervention does not only have cumulative impacts, but actually starts having greater impact than the sum of the parts. So in focusing on a specific area and trying to create healthy systems in that area rather than just doing ad hoc interventions, you actually have a greater final impact. So that is really important. And the other very important thing is relationship. In the Eastern Province, it's a longer story than we can tell today, but it was a real God connection that Mpanji is sitting on this webinar, because he's the person that connected us to the Ministry of Health and specifically to the Ministry of Health's team in the Eastern Province of Zambia. And those relationships, those connections are critical. It's not often that, quite frankly, not a very large organization like EMI, if you compare us to some of the really big players in healthcare in Africa, where we do significant work, but we're not a big player. And to be invited into the room with the Zambian Ministry of Health, with just such open doors to participate with what they're doing and being given the opportunity to come alongside their efforts has been an incredible opportunity. So I would say those are the two big ones: cumulative impact and relationship.
Amazing. Next question I have for you guys is, do the healthcare facilities in Eastern Province also receive patients from across the border?
Mpanji.
Yes, so actually both facilities that would like to start with. First of all, I would say almost all facilities, but then I'll classify where these patients are coming from. Nyanje, for instance, does receive close to over 40%, close to 50% of patients from Mozambique, and you would find that these patients coming from Mozambique, they are properly not accounted for, even in terms of planning, in terms of medication. So they do even stretch the capacity of the facility, because when the planning is done, it's planned for the Zambian population, but significantly we have patients from Mozambique. The Tauke district as well, we've also seen it does also receive a good number of patients, first of all, not only from the district, from the other district, there's a district called Lusangazi, but even from patients from Mozambique as well. Then even in terms of these facilities that we're talking about up north, like Chasefu Mini, there is also the patients there will come from Malawi, because it's also closer to Malawi. So we've seen also patients coming from Malawi, accessing facilities at Chasefu, but even some in Lundazi.
Great. Thank you so much, Mpanji. Another question we have for you is, can you speak a little about the collaboration between the architects or planners and the clinicians on site? Is there a process for transition planning and supporting them as they continue their clinical work in their new space?
Sure, Hannah, that's a big question. Could we do a separate seminar on that, please? I we are Our South African office has actually declined projects because we could, as non-clinical professionals, just through observation, see that facilities, sometimes the primary thing that they need is actually operational support, not new buildings. And we forget that new buildings can be a burden. If you have a new surgery, you have new costs. And if you're highly resource constrained, just the additional costs of medical gas, of electricity, of the cost of doing the operations. Doing an operation is an expensive thing. In a country like Zambia, healthcare is free. So if we don't understand how new infrastructure and operational constraints and requirements come together, we're not really always helping. In fact, we can be hindering. So bringing those two very different professional inputs together is critical. Dr. Jason Fader for our office has been an incredible resource. Having somebody who's developed a small rural clinic effectively into a referral hospital, who's been on the ground, who has a wealth of knowledge, he's been incredibly valuable. But we've worked with many other partners as well. We mention him because he's one of my heroes. You should see some of his photos of the operations that he does. But we're also working with people like Mpanji and Ellery who work within EMI, work for EMI, who are public healthcare specialists. We're working with, as I mentioned, business planners. In Angola, we've also worked with change management consultants to help the hospital transition through major growth. At hospitals like Minga and Patauke, we're not looking at very significant growth in the overall scale of the hospital. We're improving facilities, but sometimes at hospitals, we're very significantly increasing the scale of the hospital, which requires drastically different ways of doing things. The way that that practically works for us is involving those professionals from the early stages of conceptual work all the way through implementation. Because as we build new buildings, we need new systems in those hospitals, and we try and support and assist local leadership to develop those for themselves, but not independently of some additional expertise and knowledge. And that's a very big part of what we're hoping to do in the Eastern Province is through our relationship with the ministry, continue supporting the ministry and their work, but also supporting the individual facilities. I could speak on this for half an hour. I'm going to stop myself.
Thank you. The next
Drop me a
question.
mail. We can chat a lot more if that is an area of interest. And if you're asking how can I get involved, if anybody on this call is a medical professional and you're going, can I help? Yes, you can. And if you want to know how, please connect.
The next question, it's two questions I'm putting into one, but yeah, what architecture, engineering, and other disciplines do you need volunteers for? And are there any opportunities for unqualified volunteers?
uh, Architects with or without healthcare experience. Sometimes having somebody without the healthcare experience helps because you've got a fresh pair of eyes. We get stuck into ways of doing things. So healthcare experience is not a requirement. Civil engineers, electrical engineers, mechanical engineers, structural engineers, people with construction management experience, quantity surveyors, land surveyors, people within the medical field. We have a nurse with significant experience in maternal health care, reviewing and advising us on the Patauke project, as an example. Um, if you are an unqualified volunteer, I would question whether you really are unqualified. We're all qualified in something. So, as an example, if you're a nurse, you know better what it is like to work in a hospital than I do. If you're a teacher, you know better than I do what it feels like to stand in front of a class. So I think there are opportunities for people who are not qualified in the design professions to work in projects where they do have a knowledge, where they are able to give input. So, Lisa, I see that's your question. I'd like to have a conversation with you about your unqualifiedness And I think in that conversation, you'll find that there are areas where you can actually be of support in projects. It's about finding the right fit.
Amazing. Has any research been undertaken to determine what proportion of the third level of delay can be attributed to infrastructure constraints? Furthermore, is there evidence quantifying the potential reduction in these delays resulting from targeted infrastructure improvements?
Yeah, can I take that, G, or would you like to take it?
Please do.
Okay, so yes, in terms of researching into this, so the third delay, like I said, the Ministry of Health has identified this delay, but also this was also the work of the UNFPA, I think United Nations Population Fund or something. So they did collaborate with the Ministry of Health to identify where some of these challenges were in terms of maternity issues. And yes, we've seen practically, I would say I can give an instance of the project at Minga. G, maybe you would even speak more to this. You would find that where the maternity ward was placed at the facility, it was far behind, far from the main facility and where there is the operation room. So you would find that in as much as the patient has reached at this facility in time, the access route was further downside, but with the change in design, the master planning, I've seen that we've opened up an access route straight from the operating room straight to the maternity ward, so that in itself is going to reduce on that delay, because yes, this patient has come to the health facility, but it shouldn't take them so long to move from one service delivery point to another service delivery point.
And just to add to that, when we do healthcare projects, we baseline to be able to determine the factors that we're hoping to impact. So we look at things like overcrowding, we look at delays, etc. We develop a log frame for that project with the baseline, and then we look at impact. So that is part of the individual projects as well.
Amazing. Next question I have for you guys. The Ministry of Health annual budget in comparison to Minga Hospital's construction budget is alarming. What is the budget? Why is the budget very small? How can this change? Will improvement of the healthcare facilities in Zambia rely entirely on donors? And doesn't this affect sustainability?
Yeah, maybe I can take that as well. So
you can start and then I'll add.
Okay, sure. Yeah, thanks. So in terms of what G talked about, of course, that's a maintenance budget. We know that the entire budget for the Ministry of Health is wide in terms of paying for staff salaries and the like, but this one is limited. Of course, the administrative cost. We know that, like I said, the Ministry of Health, centrally, there's a Ministry of Health headquarters and there's a provincial health offices in these 10 provinces that I talked about. So that budget is for the provincial health office, meaning one of these 10 provinces, like in Eastern Province. But we do know that there's some interventions that are made directly from the central level. I can give an example. One of the big health facilities, Kalindawalo in Eastern Province, it was built centrally, from the Ministry of Health headquarters. So we know that there's some development that does happen, not entirely on the province. There is a Ministry of Health headquarters, but also there's what we call a devolution. So the Ministry of Health at district level, from the level ones going down, they've been devolved to the council, to the local government. So we do know that the local government also does receive quite significant funding. There's what we call Constituency Development Fund, and every council does receive this funding. I might not talk about that amount in dollar terms because I'm thinking of it in kwacha, but we know that some of the facilities that we've been to, they've been able to do some projects funded by the Constituency Development Fund. So in terms of support, yes, there is a provincial health office, there is support from the national level, there is significant support from the donors, but even from the local authority, this Constituency Development Fund, we've seen that health facilities are also being supported in terms of renovations and constructions.
And very briefly, just to add to that, the Zambian government is doing, I believe, actually, especially lately, a really good job in an environment of very significant financial constraints. The country, whilst it's physically incredibly big, has quite a low population, about 16 million Panji. So it's a low population, low tax base. So government's capacity to provide facilities in such a sort of spread out environment makes it very, very challenging. But the answer isn't just donors or just government. I think partnerships is the important thing. And I think the humanitarian sector, specifically the faith-based humanitarian sector, has an incredible opportunity not to step in and do it for Zambia, but to do it with Zambia. And a lot of that is initiatives by people in Zambia. A lot of the previous upgrades at Minga was through the Catholic Church, even through local civic organizations. We hear of hospital upgrades that happen. So the answer is partnership, not one means of addressing the challenge.
All right, unfortunately, that is our time for today. Thank you, Harat and Panji, and also thank you everyone who joined us today. We just hope that this conversation has given you a deeper understanding of the work that's taking place in Zambia and the many partnerships helping to shape the stronger healthcare facilities and the systems for the future. And then also at EMI, we often say that we are designing a world of hope. And today's discussion is a wonderful reminder that meaningful change happens through collaboration, faithful stewardship, and people who are willing to use their skills to serve others. So if you'd like to learn more about EMI South Africa, please head on over to our website. I'll pop a link down in the chat and that you can follow through. Follow through on our link tree as well to get involved. There's various links there for you to reach out to us on social media, subscribe to our newsletter, or even just read the Zambia feature story that went out earlier this year in our Inside EMI publication that we send out. Thank you so much, everyone. On behalf of EMI South Africa, thank you again for spending this time with us. We are grateful for your interest, your encouragement, and your partnership. Have a wonderful day and God bless. Thank you, everyone.